Welcome back to Good Law, Bad Law. President Trump has been blocked by a federal judge in implementing the president's plan to require drug companies to include the list price of their drugs in any television advertising. But the issue remains. We pay a lot for prescription drugs and other medications. It's a huge part of our overall healthcare budget as a country, and something's got to be done. What can be done? What are some of the different proposals to address this? My guest, Robert Field, is here to help us understand all that. Professor Field is with the Thomas Klein School of Law at Drexel University and also has an appointment at the Dornsife School of Public Health. He's a nationally known expert in healthcare policy and healthcare reform. We have a great conversation. He's so good at explaining the issues very clearly, very concisely. If you want to understand what seems impossible to understand, and always to me has seemed impossible to understand, stay tuned for this great episode. I know you'll enjoy. In today's episode of the program, we're going to be talking about healthcare and drug company pricing specifically, and President Trump's attempt to require drug companies to list in advertising the prices of their drugs as a way of putting pressure on them to lower their prices and help us with the overall cost of our enormous healthcare system. To help us understand that issue and why a court blocked President Trump's efforts and what other efforts are being talked about to address this huge problem is my guest today, Robert Field, a professor of health law at the Drexel University School of Law, now called the Thomas Klein School of Law here in Philadelphia, and joining me in the studio today. So, Professor Field, thank you so much for being here.
Thanks. Happy to be here.
This is something we were chatting before we got started that I have been very interested in for a long time, because it's always seemed to me that one of the problems that all of us face as people who buy health insurance, as people who consume healthcare, is the lack of transparency in our healthcare system overall. And although our president comes under attack for a lot of his policy initiatives, this was one that actually attracted me, and I said, hey, that sounds like a really good idea. So I want to talk about that, what happened to that plan of his, and then we can get into the issue more broadly still. But start by giving us some background on yourself, what you teach, and how you've come to this issue.
Sure. I teach at Drexel University, as you mentioned. I teach both at the Klein School of Law and the Dornsife School of Public Health, so I try to straddle both aspects of this. I teach basic health law, which is the law of the business side of healthcare, and I teach health policy, which is more the theories, the ideas, the policies that the laws are trying to implement. We have a bizarre healthcare system in this country. Now, every country has a distinctive healthcare system, but ours, I guess, is more distinctive than most. We spend almost twice as much as the average industrial country on healthcare. We have the largest private sector by far. About half of our spending is private, about half of it is public, and we have an arcane system of payment. Most other developed countries have some sort of universal coverage arrangement. It may be a government fund, it may be a network of private funds, but everyone is guaranteed some form of healthcare coverage, and it is under either government administration or government regulation. We have bits and pieces of that here. We have Medicare for the elderly and disabled, Medicaid for the poor, Veterans Administration, healthcare for veterans, private coverage for people who are employed, which is the best kind, individual coverage under the Affordable Care Act, and each of those payment arrangements has its own relationship with the providers, with the hospitals and the doctors. And even within that, they can have dozens or even hundreds of different plans, each of which has different arrangements with the providers. So to understand that is a life's work.
And then, of course, because we have the system we have, we also, even in this post-Affordable Care Act era or post-Obamacare era, we still have a lot of people who have no insurance at all.
Sure. Obamacare was never going to get rid of all the uninsurance, and of course, with the problems that it's faced and the pushback and so forth, it's covering fewer than they'd originally hoped. But we still have 20 to 30 million people in this country who don't have insurance, and they kind of get a double whammy. Not only do they not have someone else to pay their bills, but when they get those bills, they tend to be larger because they haven't negotiated special arrangements.
Okay. So and we know too that the cost of prescription drugs is a major contributor to the overall cost of our healthcare. Why is that? And how can you put some definition to that point?
Sure. So prescription drugs are important. They're rising rapidly. They're not yet the most important factor. Hospital care is still the most important factor. Prescription drugs come in at about number 3 or 4.
Okay.
However, they are 10 to 15% of our spending and rising very rapidly. Few things are going on there. One, on the positive side, is where they're developing amazing new drugs. We have biotechnology. We have drugs based on living organisms. We have gene therapy. We're doing amazing things for cancer and genetic conditions and so forth. But another aspect of it is that drug companies are discovering that when you have a patent, which is a monopoly, and you have a product that's life or death to people, you can get a lot of money when you sell it. And more they are testing the limits and maybe finding that there are no limits as to how far they can push the price.
I mean, some of the cancer drugs in particular, and I know my own father was dealing with this, the cost may be $1,000 a pill. I mean, we hear stories like that. That seems insane.
We are even getting some gene-based therapies that are pushing $1 million a year.
For the cost of the treatment.
For the cost of treatment.
Wow.
What you need to do is look behind that. So that's the retail price, that's the rack rate, and almost no one actually pays it. We have a complex system of bargaining that goes on. Generally, there are these creatures called pharmacy benefit managers who do the bargaining, and they arrange for discounts, and they, in theory, pass those on to the insurers who pass them on to the patients. It's complicated. It's not clear. It's a very efficient system, but that $1,000 a pill price tag or the $1 million a year price tag is usually substantially discounted. It's still a lot of money. But that number is, the sticker shock is not always what comes out of your wallet.
Well, and that becomes important in understanding what the president's initiative has been directed at. But before we get to that, I also want to mention that in addition to your teaching, in your life before teaching, you worked as a lawyer and represented some big hospitals in our community, Philadelphia, and actually worked for the Penn health system for a time. Is that right?
That's right. So I was in private practice for a while and represented some of the largest teaching hospitals in Philadelphia. It was in the mid-90s. It was an exciting time in healthcare. Everything is an exciting time for healthcare. It's always something major is going on. But it was when managed care was starting to take over, and hospitals were realizing that standing alone, they were very vulnerable in the market, and so they were merging with other hospitals, acquiring physician practices, looking to build strength in numbers. And then, yes, I worked at the University of Pennsylvania Health System in the late 90s when they were acquiring physician practices to, again, build a network that would have strength in numbers and would be more viable in terms of the payment arrangements, and also would be more capable of coordinating a range of care.
Okay, so let's talk about drug pricing. And since he's been in office, this has been something that President Trump has come back to again and again. I remember early on he convened one of those meetings in the White House with a bunch of executives around the conference room table. And the one in particular I'm recalling was a lot of drug company executives, and he went around and introduced everybody and then said, you got to bring down your drug prices, come on, in his very unique way. But more substantively and more recently, he announced an initiative to require drug companies to include the list price of their drugs in any television, I think it was limited to television, advertising. Tell us about that and what you think he was getting at. And then we'll talk about why a court very recently decided that he couldn't do that.
Right. So prescription drug prices are an interesting issue because there seems to be bipartisan agreement that it's important, at least so far. We haven't gotten into the detailed solutions, but across the political spectrum, from Trump to Nancy Pelosi, everyone feels that this is a problem and that it's appropriate for the government to do something about it. Trump has had a couple of ideas, neither of which have gone anywhere yet. The Democrats have a few ideas. Maybe we can get into some of those. One of the initial ideas that Trump had, which seemed pretty simple and fairly benign, was to say these outrageous prices, put them on the TV ads so that people know how expensive these drugs are. And the drug companies dominate the evening news and much of nighttime TV.
That is absolutely true.
With their ads, so that people would not only see these attractive, healthy-looking actors and actresses getting cures and treatments, but they would see this is $1 million a year. This is $1,000 a pill. A court struck this down. The pharmaceutical industry sued and said it was a First Amendment violation, that you can't restrict what they can and can't say about their products. Would it have accomplished anything? It's not clear. As I was describing, most patients don't actually pay full freight. They'll pay a deductible or a copayment. So the price that your insurer pays is much lower, and the proportion of that you pay is much lower. What it might have done is to shame the companies, so that people would actually see, you say this is a great thing, is it really worth this incredible price? Would it have had an effect? It might have, but it's not the silver bullet by any means.
Now, some drug companies, I was reading, anticipating this, because Trump was talking about it for a while, and until this was a judge in Washington, D.C. in federal court, a bunch of the drug companies got together and sued in federal court in Washington, claiming that the agency rule from the Department of Health and Human Services violated their First Amendment rights, and they won, and the judge ruled that the plan could not go into effect for that reason. We still don't know if there'll be an appeal. Excuse me. But anticipating all this, some drug companies have started posting voluntarily this information on their website. There was one in particular, a drug, I think it was Xarelto, that Johnson & Johnson posted the monthly list price of Xarelto, which is an anti-stroke drug, as $448. This was according to New York Times. So even though the initiative was struck down, at least for now, maybe there will be some move towards greater transparency on a voluntary basis. I don't know. It doesn't seem like you think that even if that were to happen, that would be that meaningful. Because it doesn't really tell us what any of us are actually paying.
It doesn't. And I think there's a big difference between putting something on your website and putting in the TV ads. The TV ads are literally in your face every night. And every time that drug is mentioned to millions of people, there's the price. How many people dig into the website? Probably a small percentage, and how many of them are going to dig down and see the price?
Right,
so I think it's going to have a very different effect. And if the real effect here is the publicity and the shaming of the companies, it's going to be a lot less powerful when it's somewhere in a website. An example is starting earlier this year, hospitals were required to post their chargemaster rates, their rack rates, and that is extremely complicated information. It's very hard to make sense out of, but it's there on their websites. It's public. It will have almost no effect in terms of how people perceive the prices, but it's there. And I would worry that the drug companies posting their prices would similarly fall short.
Well, let's say a few more words about that, though, because I was going to ask you about that. And that is another initiative that the Trump administration prompted, and it is in effect. The hospitals post their charge master. That's the sort of like the master price list, right, that has the list prices for literally tens of thousands of procedures, charges, different little pieces of what goes on, or little pieces of what are the overall total of what somebody goes to a hospital to get. Might be the room, might even see a separate charge for the TV. I don't know. Right, it's not one of the problems with posting these charge masters is trying to make any sense of it.
Part of the complication of our issue is there are sort of these alternative universes. The charge masters are a throwback to decades ago when there were actual prices for every service the hospital provided, and then either you or your insurance company paid that. A lot of people have dug out old hospital bills, from the 50s and 60s, where it actually listed the TV was this much, right, and the doctor service was this, and the aspirin was this. That's a universe that hasn't existed, at least for the last 20 or 30 years. What actually gets paid to them is a negotiated rate, usually a bundle. Medicare and Medicaid pay them based on the diagnosis of the patient. The private insurance companies do a combination of that and a per diem rate for each night. It doesn't matter to them what the Band-Aid costs and what the aspirin costs. It's all bundled together. So it's sort of a distant mirror of an earlier time that no longer makes sense.
Well, and so one problem is you don't know exactly what the bundle is for your, let's say you stay in the ER for a night and you get an ultrasound and they give you 2 different medications and an ER doctor sees you, but also, you've got to piece together all those different components to understand what the actual cost is. And even then it's not the actual cost, as you've said, it's the list price, not the cost you're paying. I would have thought there would have been a greater move towards demanding true transparency, comprehensible transparency in an era we are now in where more and more those of us who do have insurance have high deductible plans where we're actually paying the first X number of dollars before our health insurance actually kicks in and pays from that point on. So, I'm very interested to know what things actually cost, but we don't really have any way of finding that out.
Right. Well, just as the pharmaceutical companies have fought against having to display their prices on TV, the hospitals have fought against having to display the prices they actually receive from the insurance companies. And it's very hard to get that information. Most of it is considered trade secrets, it's proprietary, and really no one other than the insurance company and the hospital know what it is. We have teams of people, thousands of people in this country, working on each side of the equation, negotiating how all of that is going to work. One of the aspects of our system is not only do we have the biggest private sector and the most expenses, we have the largest administrative costs of any system. And a lot of that is because of these complicated negotiations. And we don't even know what they result in because we don't know what the prices ultimately are.
Well, so as you pointed out, we all, I think, agree, maybe the drug company executives don't agree, but I think most of us agree that we've got to do something about the cost of healthcare, and we've got to find probably multiple ways of attacking the problem. Let me mention a couple of other things that I know I've heard of, which is one is that the VA, which as you mentioned to us, provides basic medical care to veterans, has a I'm going to see if I'm saying this right, correct me if I'm wrong, but has some preferred pricing for medications that it gets for its
Right.
for its patients.
Right.
It's the lowest available rate or something like that.
Yeah. It and the Department of Defense negotiate with drug companies over what they'll pay. And because they represent millions of people, they get very good prices, which tend to be among the lowest.
Right.
So that negotiation can work.
But it doesn't apply to Medicare. Because I thought one initiative that's been talked about is to apply the same requirement that why should Medicare, which is another monstrous-sized healthcare provider, pay more than what the VA is paying for Xarelto or for any other drug.
Right. Well, actually, there is a provision for Medicaid programs to get the best rates. But for Medicare, which covers about 50 million people, that is true. Although you have to dig down a little bit deeper. There are really three categories of prescription drugs. One is what's administered in the hospital, what the anesthesiologist gives you to knock you out and bring you back. Those are part of your hospital stay, and they're included in the bundle that's based on your diagnosis. Then there are the drugs that are administered in a physician's office. Those tend to be oncology drugs where you need an injection and you can't just go to the drugstore. Those are under a whole separate program. And the administration actually has recently taken steps to try to ratchet down those prices, and particularly the markup that the physicians are able to get from what they pay for the drug to what they charge Medicare. Then the third category is what we tend to see that's more visible to us is the prescription drugs, the ones that you get from the drugstore. That's where Medicare does not have the ability to negotiate for everyone. The idea behind the prescription benefit, which was enacted in 2003, was we'd have a lot of private companies. You get that coverage through a private insurer, and that they would negotiate. And they do, and sometimes they get decent rates, but they're not negotiating on behalf of 50 million people. So they don't get as good a rate as they would if you had unified bargaining.
So we talked about the advertising initiative as maybe a way of shaming the drug companies, and I hear some doubt in your tone and your explanation as to whether it be realistic to expect that to happen. What else can be done, or what else is being done? I mean, we can start there, that you think could be more effective and could bring about better results.
There are many ideas. Some of them are more incremental than others. And this is a major issue in the Democratic presidential campaigns. One thing that Trump had wanted to do, in addition to listing the prices, was to get at these middlemen, the pharmacy benefit managers. They operate in a very bizarre way. They don't negotiate a direct discount. What they do is negotiate a rebate.
Yes.
So they pay the full price, and then they get money rebated, refunded to them afterwards. And there's a lot of controversy over how much, if any of that, actually gets passed along to the patient.
Or the employer, if it's an
or the insurance company,
plan.
or the employer. So they're actually not the only middleman. You actually have layers of middle people, but they're the key ones in terms of negotiating for the drugs. And there's been a lot of focus on them recently for keeping those rebates and not passing the discounts along. And the drug companies point their fingers at them. It's interesting, actually. A lot of them are now owned by or affiliated with drug company chains, CVS, for instance, and some of the others. So it gets another layer of complexity. But what Trump had said he wanted to do was to get at them and restrict their activities. And they have abandoned that, at least for now. So that remains a possibility, and that could again have some effect. Another is to allow Medicare to bargain directly. They would be bargaining again for 50 million people, and the idea is that that price would then be a benchmark that private insurers could follow and that patients could then follow when they're trying to see whether they've been ripped off or not.
Well, let me ask about that, because I think that's an important point, that you start with a list price, whether it's for a drug or looking at the charge masters. We've gone through that, and then Medicare negotiates a discount off that list price for its insurance for those 50 million people.
If this went through, you mean? Yeah.
Well, I mean otherwise.
Yeah.
I mean, Medicare negotiates for all the other things that Medicare covers.
Right.
And then private insurers use that, and you use the term benchmark, they will negotiate off of the Medicare discount. So they might do Medicare plus 10 or Medicare plus 20. Right. They won't negotiate as good a deal as Medicare can get, but they'll know what Medicare's discount is, and they use that in their negotiating. So if I understand what you're saying, if Medicare had the ability to negotiate directly on prescription drug prices, that would not only theoretically reduce the prices for Medicare insurance, but because other insurers use Medicare as a benchmark, it would allow them to negotiate better prices for their insurance.
That's the theory.
Right, that's the theory.
And we don't know whether it would work because we haven't tried it yet. But it would set a reasonable rate and then presumably would pull a lot of the private plans along with it.
Okay.
Another idea, which Bernie Sanders has been promoting, is to allow us to import drugs from other countries. Going to Canada, that has been something that people have been doing now for 20, 30 years. Their prices are much lower. Prices in Europe are much lower. The reason is that those governments control prices. So we're basically piggybacking off of their price negotiations. The Canadians are not thrilled about this idea. They don't want millions of Americans coming in and buying drugs, and then their citizens have to wait in line behind the Americans. But the idea is that if we could bring drugs back in at the lower prices, it would be a way around the high costs.
I think you can get them by mail order. Or certain ones you can anyway.
There are mail-order pharmacies from Canada.
Yeah.
You do need to be pretty careful because you don't know exactly what you're getting. You're much safer if you physically go to a drugstore in Canada, but there are mail-order pharmacies.
Well, and it'll be news already by the time this episode posts. But I know I was noting on the I saw actually Senator Sanders interviewed this morning, the day we're recording this episode, and he's talking about getting a bus and traveling to Canada with some diabetic patients to buy insulin across the border in Canada, because I gather you can get insulin a lot more cheaply in Canada for the reasons you said. But that also suggests something about the issue of drug pricing that you and I were chatting about earlier. I want you to make that point because it's a good one. Why is insulin... Why is the story of the price of insulin somewhat different, say, than the price of some of these other big ticket drugs that we've mentioned?
Sure. First, I should point out that for the last 25 years, politicians have been getting on buses to Canada with senior citizens, and in a way, it's kind of discouraging because we've been at this for quite a while. Insulin has been around for 80 years. It's a life and death drug if you have diabetes. It's been off patent for a long time. So there really is no objective policy reason to jack up the price. Some companies tweak it. They make different formulations, different routes of administration, but we're talking about a substance that has been in the public domain for decades and decades. The argument that the drug companies often use is they need the high prices to fund research and innovation for the next generation of drugs. No research has gone into insulin or to develop insulin, again, for decades. That's different than the patented drugs, many of which are path-breaking. If you look at biotechnology, gene-based drugs, a tremendous amount of money, maybe billions of dollars, goes into developing some of those drugs. And there, at least there's an argument that the high prices are supporting the research that makes them possible.
And the research that was needed to develop the drug, to strike out a few times before they got to the right... got the right pitch to hit and all that. So you can see that, and yet I have to say, as we're working our way through a number of these different proposals, it's just another point to be discouraged about if you're looking for ways to, find some vulnerability in the system where we can make a difference in terms of pricing. So, Trump may have the right idea, but so far hasn't found the right path. And I don't think he's going to be getting on a bus with Bernie Sanders anytime real soon. So
yeah, I don't think he gets on buses.
Right. So what do you think? Looking at the playing field that we have, what do you think we should be focusing on and talking about as the most realistic approach to the issue of drug pricing?
Well, one issue that's been researched, but more information would be helpful, is to look at the argument that the high prices in the U.S. are funding innovation. How much of that actually goes to innovation? How much of it goes to marketing and other aspects of their cost structure? That's been controversial for a while. And I think tighter oversight of that. There's a broader issue that the drug companies say, well, if we had European-style prices in this country, we wouldn't have the revenue to fund the innovation. And then you have to ask, well, so why are U.S. patients and U.S. taxpayers the ones to fund this for the rest of the world?
Yeah.
If we're going to do that, there are fairer ways of doing that. If it were up to me, I'd be looking to put a bigger role on NIH, National Institutes of Health, which funds a lot of the drug development process. It funds most of the basic science that goes behind the development of actual prospective drugs and some of the clinical trials that go into developing the drugs themselves. And I would look to see whether we can put more of the burden into NIH. That would involve more government spending, obviously, but we'd be taking money away from those high prices that we pay. So we might end up coming out ahead in the end.
Well, I want to understand how we would be doing that. Is that because an NIH-funded drug development wouldn't have a patent attached to it?
No, they end up having patents attached to them. NIH often works with drug companies, and generally the end result, because of a number of government programs, is that the company does get a patent and does charge high prices. I think if we moved, and I'm talking very theoretically now, if we moved a lot of the drug development to NIH, there'd be less reason to maintain the high prices. And I think from a policy perspective, more rigorous price controls would be more justified.
I mean but you would still have to have a mechanism to regulate drug prices.
Yeah.
And we don't have an agency present that does that or could or has any authorization from Congress to do that. So
this would require some kind of renewed regulation.
Yeah. And
I think it's going to be hard to get a handle on this without having something. We have all these disparate payers. They each have a different price scheme. The ones under Medicare, under the ACA, under employment insurance, you have the Medicaid programs, the VA, all of this. And so the drug companies really don't have one payer that's the 800-pound gorilla that they have to bring down the prices to meet. They do for the VA and Medicaid, but in terms of the preponderance of the population, there's no 800-pound gorilla that can really throw its weight around in terms of the overall cost of drugs. And that's why European countries and Canada are able to bring down prices and we're not.
Well, I guess that's the place to end then, which is we could have a system of a single payer system. Some running for president are now calling it Medicare for all, or some variation of universal health insurance. It's been talked about, as you said, for a lot of decades in this country, and I don't know that realistically we're any closer to seeing something like that happen. But that would be a way. Would be to join with other countries like Canada and the UK and have a single system, and then you have one entity negotiating and saying, look, this is all we're going to pay.
Right. We wouldn't actually need a single payer public fund to do everything to do that. We can do that with regulation. A lot of when countries set prices, it's anything but arbitrary. They put a lot of effort into looking at the actual cost to develop the drug, the clinical value of the drug, how many patients need it. So we could be doing more of that. It's called pharmacoeconomics, looking at the actual economics of the drug. It wouldn't have to be that the government is the sole payer, but we would have some sort of framework for the private payers in terms of what they're paying for the drug. So there are many ways of going at this. I think unless we do something fairly substantial, we're going to be nibbling around the edges, and we're not really going to get a handle on this.
And the court, the federal court that struck down President Trump's efforts to require drug companies to include pricing information in their advertising, did so by finding that the Department of Health and Human Services had exceeded its regulatory authority. And this is a big issue when we look at the role, very powerful role that all the varying agencies have in setting regulations. And that's a big topic for another day, that Congress has sort of created these agencies but been not as diligent in being very specific in defining what the reach of their authority is. But this judge in this drug pricing case found that HHS had exceeded its regulatory authority. Theoretically, Congress could very specifically define, either through the Health and Human Services Department or some other agency, and give authority to do just what you're talking about, engage in the kind of analysis that other countries engage in, and set regulations on pricing.
They absolutely could. So far, we've seen fairly mild proposals. We've talked about requiring the prices on the TV ads and perhaps doing something about pharmacy benefit managers. And we've had more of a feel-good bipartisan consensus on this than almost any other issue. But when the rubber hits the road, if we're really going to propose new regulatory authority for the government, I think that's when we might see the consensus start to break up. Are we moving in that direction? I think we won't really know till after the 2020 election. But if we do, I think we'll see proposals that really could make a difference, but also will be a lot more politically controversial.
Wow. Well, I don't want to say I'm too discouraged, but we've got a lot of work to do, as you've said. So thank you so much, Professor Robert Field from the Thomas Klein School of Law, and also the Drexel
Dornsife School of Public Health.
Thank you so much for coming in today. It was great to meet you, and thanks for talking with us about this issue.
Thank you.